This is the first episode of the clinical topic series. So today we thought we'll discuss about a very important and deadly diagnosis in the emergency department, aortic dissection. Why is it so important? Is it very common? Probably not. But everyone is worried about missing an aortic dissection because the clue is in the name, dissection. People die a lot if you miss it. So not wasting any further time, we'll speak to Lakshay. Lakshay, can you just start briefly by explaining what exactly is aortic dissection?
So dissection, it actually comes under umbrella term of acute aortic syndromes, which covers four kind of pretty similar entities, which is aortic dissection, the part of acute aortic syndrome, and then there is one what we call it penetrating atherosclerotic ulcer, and the third one is intramural hematoma, and the last one is aortic rupture. Now, some texts don't include that because essentially if aorta ruptures, most people don't make it. So these are the, let's say, three terms which come under this umbrella of acute aortic syndrome. So when we see somebody with sudden worrying chest pain, we actually suspect acute aortic syndrome, which can be dissection, intramural hematoma, which is a hematoma in the wall of the aorta. And the third one is penetrating atherosclerotic ulcer, which is a generally old age disease, hypertension related or smoking related. So that's what dissection is. In terms of what actually happens in dissection, just to remind our users about the anatomy. So there are three layers in the aortic wall or wall of a blood vessel, which is tunica intima, innermost, media, middle layer, and adventitia, which is the outermost layer. In dissection, there's a break in the integrity of tunica intima, which is the innermost layer, because of various reasons like high blood pressure or smoking or connective tissue diseases. We'll talk about the risk factors in a minute. So when there's a tear in the tunica intima, the blood kind of tracks through and flows between the two layers. It can be between intima media, it can go to adventitia. Sometimes it can track downwards or upwards and come back to the true lumen, essentially creating a false lumen, what we call a double-barreled aorta. So that's what dissection is. It can go to any kind of affect any organ system. It's not just a disease of the chest, which is really important to remember. It can give you sudden onset abdomen pain or any kind of neurological features. We'll talk about them.
Okay, fine. So I think that's a brief explanation of what dissection is. You mentioned one of the risk factors, that's smoking. Are there any other risk factors for dissection?
I think big risk factors that come to my mind are hypertension. And I say smoking because smoking is a risk factor for hypertension. So smoking, hypertension, connective tissue diseases, really big one. Somebody with Marfanoid body habitus, Marfan syndrome, because of connective tissue pathology, Ehlers-Danlos, even Turner syndrome is a risk factor for dissection because they generally are, it is associated with the coarctation of aorta. Other things that increase your susceptibility for dissection are homocystinuria. Even pregnancy is kind of a risk factor for coronary artery or acute aortic dissection. So these are the really big risk factors for dissection. The other one is, the last one is bicuspid aortic wall, which just changes how your blood flows into the ascending aorta.
Okay. Moving on to the next question. So whenever you read something about the dissection, you always come across something called as Irad or Irad Registry. What exactly is this and what do they do?
So Irad, it is kind of the biggest registry which collects data from about, I think, 11 countries or 30 centers of excellence across the world, because this is acute life-threatening condition. So it's difficult to do a RCT on this. So most of the data that we have is retrospective, and we're not really clear whether we have the exact numbers or not. So that's the biggest registry. There's another German registry, but people mostly talk about Irad registry to understand the risk factors or to understand the clinical presentation of dissection. So that's what Irad is.
Okay, fine. So just to clarify one more thing before we head on to the next question, is there something called as a dissecting aneurysm?
So people take really
all the dissections are they like preceded by aneurysm?
Some people get offended with this term, dissecting aneurysm. They say there's nothing like that. Generally speaking, these are two different, totally different disease entities. So dissection is when you have a tear in your intima, and aneurysm is when you have abnormal dilatation of blood vessel, in this case, aorta. Aneurysms can dissect theoretically, and it does happen. It's a rare thing to happen when you have an aneurysm and that dissects. But generally, we say whether you're suspecting dissection or aneurysm based on the history, but it is possible to have a dissecting aneurysm.
Okay. Just to clarify, is it possible to have a dissection without aneurysm?
Totally. Yeah. It is possible to have dissection without aneurysm. Yeah.
Oh, fine. So, all right. So we spoke about Irad Registry. So whenever I look at some of the missed cases of dissection, so it's not something, when you look at the symptomatology, it's not something that you would usually think about when you look at the symptoms. And the symptoms can be quite non-specific. So
yeah.
When would you think a person is having a dissection? What are the common symptoms of dissection?
So classical, if somebody reads a textbook and then they have a dissection, so classical symptoms. So any disease, classical presentation is rare. About 1/3 of any disease presents classically. So classical symptoms for dissection are abrupt, really abrupt. This is the key question. I think your money is in history when you are thinking about dissection. Abrupt onset chest pain, what people sometimes say thunderclap, like thunderclap headache or thunderclap chest pain. Abrupt onset reaches the maximum intensity within seconds. This is a vascular problem, and vascular problems give you immediate symptoms like stroke or dissection or subarach. So maximum intensity pain, abrupt onset reaching peak within seconds. The other big ones for dissection can have migrating pain depending on where you are dissecting. So if you dissect, pain might start in your upper chest, then might go to your abdomen, might come to your limbs. So think about dissection when you have symptoms above the diaphragm and below the diaphragm. Pain which is not responding to big doses of opioids. If somebody's at 30 of morphine, IV morphine looks uncomfortable, of course, think about dissection. The other important exam finding would be pulse deficit. Now, this is different from blood pressure differential. Pulse deficit, discrepancy in pulses. One is feeble, one is quite pounding. It can be upper limbs or lower limbs. The other one would be big, kind of big neurological symptoms, not just a bit of tingling, but say weakness or kind of strange feeling in your hand, or again, pulse deficit, but neurological symptoms, because dissection can give you symptoms anywhere. It's not, as I said, not just a disease of your chest. It can go up to your carotids, can give a stroke, vertebral artery dissection. It can go to your subclavians, can cause monoplegia. Spinal artery can cause paraplegia, can cause monoplegia in your lower limbs. It can go into your femorals or renal, classical, coming with hematuria. And we say, oh, think about dissection in a 30-year-old or a 40-year-old coming with abdomen pain, but some blood in the urine. Don't just send them home with thinking this is renal colic. So it can really go anywhere. It can cause bowel ischemia. Sometimes it can go to your coronaries, can cause inferior or posterior MI. So it generally can cause any symptom, but the big ones will be migrating pain, sudden abrupt onset, pulse deficit. Sometimes they can have AR, aortic regurgitation murmur. 1 in 3 of them have that. Syncope, 1 in 10 of them have syncope. It is rare. Generally, they have other symptoms as well, not just isolated syncope.
Right. Now, after listening to all the symptoms, I'm a bit more confused now. So when would you decide you need to scan someone or do a CT of their aorta? And when you look at various literature and when you go to textbooks, one common term that often comes up is have a high degree of suspicion. So what exactly does it mean? When will you suspect there is a dissection? I know you've kind of described all the symptoms, but can you give us a few like bullet points? If you have these, your degree of suspicion or index of suspicion should be high.
So none of these historical symptoms, or again in dissection, none of the tests, blood tests, rule out dissection.
Yeah.
But if quite a few of them are negative. We'll talk about investigations. The X-ray is totally fine.
Yeah.
And if their ECG is normal, they look well. You've watched them for a while, they look comfortable. Generally, these patients look uncomfortable. They're not walking around in the emergency department and asking for a sandwich or going out for a fag. They look uncomfortable.
Mm-hmm.
In terms of increasing your suspicion, again, if somebody looks uncomfortable, big doses of opioids, classical stories, sudden, abrupt, thunderclap chest pain, pulse deficit. People talk about blood pressure differential. Now, 20% of people, normal people, have that anyways. So I wouldn't make decision just based on that blood pressure differential finding, but it's good to check that. That only happens. It's important to clarify that only happens if you have dissected your subclavian. Only then you will have blood pressure differential. If you are just having a dissection here in your arch of aorta or abdomen, you will not have that. That's the reason why it happens, is because you have dissected the subclavians. So again, increasing my suspicion would be classical history, looking uncomfortable, risk factors.
Okay, so to summarize that all, any classical history would raise
risk factors. I would also look at risk factors, but even in the absence of risk factors, with a classical history, I think it's reasonable to scan them. The stakes are really high. We don't want to miss this diagnosis. And as of the data that we have now, we miss about 1 in 3. So we are not good at it.
Okay, and there's no pathognomic sign or symptom which kind of can rule out dissection. There's no one single symptom or one single sign on examination that can kind of rule out dissection. Is that correct?
No, there is nothing that you can say, oh, this is not dissection, or if blood pressure is normal, this is not dissection. There's no single finding. But if you have 5 or 6 negative, somebody looking well, young,
and it's got
you've watched them for a while, kind of asymptomatic now, then it's a thin line. We don't want to scan too many people. It's a thin line between using your resources and you don't want to miss as well. So if quite a few things are negative, they look well, sensible, asymptomatic. Yes, it's reasonable to have a chat with them. Tell them it's highly unlikely. You are well now. Your pain is gone. I don't know what it is, but I don't think this is dissection. If I were you, I would probably wait and ask them what they would want to do.
Okay. All right, fine. So going on to the next question, I think you kind of partially touched on this topic. We do this a lot. We check blood pressure on both sides and say they are normal and probably it's not dissection. Is that kind of definitive? If somebody has got like equal blood pressures or no significant difference between both the arms, can they not have a dissection?
So as I said, there's a study that it was in an emergency department where we checked blood pressure for all the patients in the emergency department. 20% of them had this anyway. I got this done once. I had 18 millimeters of difference. So generally what people consider significant is 20 millimeters of systolic BP difference in both arms. This by no way can rule out dissection. Dissection is a disease of your aorta, and aorta is in your chest and abdomen. And again, it can go to your any vessel. So you will have, it's important to remember why you have this. You have this if you dissect your subclavian, because that's where you check blood pressure. And if you have a blood pressure difference, I just want to quickly mention this here. If you have blood pressure difference, your treatment will be based on the arm or the limb which has higher blood pressure. But high blood pressure in no way, or low blood pressure or normal blood pressure in no way can rule out dissection. High blood pressure is common in these people. About 50% of them present with high blood pressure. But 50% of them can have normal or low blood pressure. If the blood pressure is low, then they're probably more sick and you've sort of missed the boat. If the blood pressure is high, that maybe slightly increases your suspicion, with a good story, of course, but you cannot say normal blood pressure, I don't think this is dissection. That doesn't make sense.
Okay. To summarize that all, if you have got a very good story, if your degree of suspicion is very high, you cannot rule out dissection just by any physical sign or symptom. And probably you should get an imaging, and that's kind of the definitive way of identifying if there's a dissection, if I'm not wrong.
Absolutely. And I just want to mention here about the nature of pain. Now, most people who say I've got sharp, stabbing, ripping, tearing pain, they will not have dissection, and we should be comfortable with this. And I know most of the scans that I'm going to do over the next few years of seeing these patients would be negative.
Mm-hmm.
And this is a high-risk condition. I don't know what's the way around it. If somebody gives a good story, has a few risk factors, looks uncomfortable, has any chest pain,
Yeah,
we should probably scan them.
yeah. Okay.
And I think I missed this point on kind of pathophysiology when you said why this happens.
Mm-hmm.
So as I said, it's a tear in the intima. So I think the best way to explain that would be imagine a hose pipe. So your aorta is, let me just grab something. Yeah. So your aorta is, imagine this is coming from your heart and this is your arch and descending aorta.
Mm-hmm.
So when your heart beats, it not only contracts, it kind of flexes as well.
Mm-hmm.
And twists as well with every heartbeat. And imagine you do this 70 times a minute. And then in a year, if you do your math, it will be about 37 million times. So if you do this 37 million times, the highest risk of dissection is in the arch and kind of after the origin of your subclavian, left subclavian artery. And if you keep doing that, there will eventually be weakening of this part and this part. And that's why the highest risk is in chest. About 62% of dissections are in chest and the rest of it are in abdomen. And if you have a connective tissue disease or risk factors, smoking, even cocaine, drug use, I didn't mention that to start with, MDMA, cocaine, or trauma can increase your risk. Traumatic dissection is a different ball game, but cocaine, amphetamines, and connective tissue diseases make this worse, increases the what they call as hydrodynamic forces, increases the force that blood exerts on the wall, which is intima.
Okay. Thank you very much. I think we'll stop here and we'll carry on with the imaging, treatment, and different types of surgeries and prognosis on the next video. Thank you very much.
Thank you.